Welcome to our session today on COVID and mental health. We have three excellent researchers. I'm looking forward to a really interesting conversation. They come to it from very different perspectives. So I'm going to let Patrick start, and they're each going to do a short presentation. Then we'll have some questions, and I want to encourage everyone who's listening to also put in some questions in the chat, and I will follow those and try to get those in as well towards the end. Patrick?
Hi, I'm a professor of psychiatry at Dalhousie University and at the IWK Health Center. The thing that the panel emphasized, first of all, is that COVID has affected everybody's mental health, and we all have experienced some of the effects of that, and that's what's captured the imagination of the media, and that's what's talked about most often. But COVID has had a specific impact on people who were disadvantaged in terms of mental health before, either disadvantaged in socioeconomic issues or disadvantaged in terms of their previous mental health problems. So that there's been everybody in these days, you know, one of my patients said, well, I asked her how she was, and she says, well, I'm COVID fine, you know, as good as it could be in COVID. We're all suffering from that. But people with specific disabilities, specific disorders have had much more difficulty. The working group suggested several things to the governments, and one of them is that this historical underfunding of the mental health area should be moved towards being corrected. We suggested a specific target of 12% of the health services budget. That's not nearly the percentage of the burden, but now it's hard to get a complete picture of what the current funding is, but it's around 9%. So we're suggesting a fairly important increase. And the small amounts of money that have been announced during the pandemic are not going to be sufficient to meet that. And usually those are one-time fundings. We do think that the standards of quality in mental health care should be established nationally in conjunction with the provinces. We totally understand that healthcare is a provincial affair, but the standards for mental health care should be established, because now there are no national standards. There are, in some provinces, some provincial standards. Another recommendation is that we should have, similar to what the UK has, we should develop improving access to psychological therapies. And they have developed a whole system of developing talk therapies for the masses, for the hundreds of thousands of people that need it. Most of the studies have been done on what people lack in terms of mental health care has been on these talk therapies where people haven't had a chance to get to them. If you're a child, you may wait 2 years to get to see a psychologist, for example. Similarly, if you're an adult wanting to have somebody to talk to about their problems in the health system, you can wait forever. And if you're not very seriously impaired, you may never get any assistance. We do think that the long-term funding for the Canadian Institutes of Health Research and the SSHRC, and perhaps to NSERC, should be equivalent to the burden of the disease, so that the mental health mental health and addictions are not well funded for research. And part of the reason is that there aren't as many mental health researchers as there are in other places, in other areas. And so consequently, it may require a specific effort rather than just leaving it up to the accidental who applies and how many people get funded. The other types of recommendations that we made include the undertaking of a national task force on the prevention of mental illness and the promotion of mental health and wellness, with special reference to pandemics and to other national emergencies, because we feel that these are going to continue. Why don't I leave it there, and the rest of the panel can talk about things, their specific areas, and then we'll come back, and if there's any other questions, we'll be glad to answer.
Great. I think I'm next in the lineup. Is that right, Erin? Okay, great. Hi, everybody. Nice to be with you, I guess virtually. I'm Alison Crawford, and I'm a psychiatrist at the University of Toronto and the Centre for Addiction and Mental Health, and have been involved in leading virtual care for the last 10 years, and that's what I'm going to focus in on. So I was very pleased to be part of the group that worked on this report with Patrick McGrath, but really my focus was on virtual care. And nothing I can say could have prepared me for the massive shift that we've all gone through in the last number of months. So even though I've had a lot of experience in virtual care, there were lots of things I couldn't have anticipated, both as an administrator and then, like many of you, as a patient, as a caregiver. My mom's in long-term care. So just thinking about what that transition that we've made within healthcare to virtual care. And I wanted to mention three things. So although there's been a lot of opportunity, and I don't think we'll ever quite go back to pre-COVID days in terms of our use of virtual care, I think there are also things that we need to do to sustain virtual care and to make more advances moving forward. And those three things that I'll talk about. The first is something that I work on with two colleagues, David Wilger and Gillian Strudwick, digital compassion. So thinking not just about the technology itself, but how we sustain relationships through virtual means. And moving beyond, like, I think we're all very glad that we were able to continue access within healthcare, but how do we think about quality of care? So how do we think about things like patient choice, in person versus virtual? How do we think about timely access, efficiency, and effectiveness? So I've got lots of question marks because I think that this is very much an area that's under development. There is research, but I think we really have to put an emphasis on that quality of care. And a part of quality of care, I think an issue that's really emerged is around health equity. So do all Canadians have equal access to virtual health care, and do they get the same outcomes? And I know at our organization, even though I think we were very aware of that issue and actively trying to ensure access, when we look at who got access within the first months of the pandemic, we see differences in terms of really any equity area you could think of. Differences in terms of gender, age, disability, ethnicity, income, housing. So all of those things are going to be so important to ensure a robust virtual healthcare system. The second thing is a different aspect of compassion, and that's self-compassion. So we know that burnout and fatigue are already issues in healthcare across different health professions. And I don't think we yet know the full impact of what it means to work in a virtual environment as health professionals, and how we maintain our own health and wellness. And then the third thing is more from a health system perspective. So, you know, we can get our relationships with clients up and running, but how as a health system do we ensure continuity of care for people? How do these, you know, sort of virtual bubbles speak to each other? What kinds of regulations do we need? What kinds of funding models do we need, and models of care do we need to have a system of care that includes virtual, not just individual access? And I think those three concerns line up with a number of the recommendations in this report. I'm not going to read them out, but certainly recommendations 10 to 13 have to do with these issues of ensuring and measuring health equity, ensuring that we have systems of care, including technology and regulations, that those are harmonized across the country, and developing stable funding models and thinking about how funding for virtual care is going to work, and for different models of care. So collaborative care is a model, or shared care, where we work across different specialties and with primary care. And then finally, training. That, you know, some of us have had a lot of experience with virtual care, so that shift was a bit easier. But how do we ensure adequate training for health professionals, but then also adequate supports for communities and patients, getting people with lived experience involved, using peer workers to make sure that people have digital health literacy and can get access to care. So I'll leave it there for now, but really glad to be part of the conversation.
And I'll pick it up from there. I'm really pleased to be here. Thanks for the opportunity to meet, and thanks to Patrick and the others for allowing me to participate and contribute to the document as well. My name is Chris Musquash. I'm a clinical psychologist by training, but I'm a faculty member at Lakehead University in Thunder Bay, where I'm a Canada Research Chair in Indigenous mental health and addiction. As well, I work clinically at a community-based organization for First Nations people in the Robinson Superior Treaty area called Diligo Family Care. So my goal was really to try to, bring some conversation around Indigenous mental health and addiction into the broader RSC COVID conversation, and again, not being able to speak on behalf of Indigenous communities broadly, but at least to share a little bit about what I was seeing in the earlier days and as the pandemic progressed. I think what the pandemic highlighted and exacerbated in many cases were known gaps in service. So things where gaps already existed, it made them worse, as well as equitable access to resources, and as well a human resource capacity to manage mental health related crises. So it wasn't long before communities were organizing and trying to draw together, teams of people to be able to support as the crisis exacerbated mental health and addiction difficulties. That was as a function of the suspension of services as a means of preventing viral spread into isolated communities with limited resources in terms of caring for the ill. Should COVID-19 have arrived there. So, for example, domestic violence shelters for women would be closed, or addictions treatment centers would be closed, and folks would have difficulty accessing those types of services. So as a consequence, we began seeing some increases in policing calls, increases in child welfare related calls for support. As well, many communities were able to set up checkpoints around their communities to help ensure that there was at least screening of people coming in and out when it came to limiting risk of infection. One of the things that also did was disrupted supply chain in illicit substances. So in many cases, people who were experiencing addiction difficulties would then have, who also had limited access to medically assisted withdrawal type services, would go into active withdrawal from the substance that they were previously using. So all that to say, the strength and resilience and creativity that a lot of communities have employed since in order to try to support people within those communities has been remarkable. And I think that when it comes to specific types of recommendations around how governments can continue to support Indigenous communities to be responsive to their needs, we asked through recommendations 7, 8, and 9 for specific things. Supporting exemplar communities, Indigenous specific programs, and Indigenous governed organizations who are leading the way in mental health, to be able to expand their resources to other communities in need, that in consult Indigenous communities, that solutions are implemented to remedy across the board public services inequities and structural discrimination that contributes to overrepresentation in rates of mental illness, and as well facilitating connected and holistic approaches to mental health care, which are inclusive of child welfare, housing, social services, education, justice, and some of these other overlapping domains that often operate more in silos rather than as a coherent system of services. So I can leave it there and say thanks again for the opportunity to talk.
Thanks to all three of you. I've included a link to the Royal Society's report in the chat when someone was asking about that. I think the one thing that the report does is also, in addition to the recommendations, provide a really good overview of the different issues that have come up during COVID, where mental health is concerned, both for individuals and also for the system. So it's a good read, and the link is there now. I realized I didn't introduce myself at the beginning. My name is Erin Anderson. I'm a writer with the Globe and Mail. I mainly cover mental health and social issues, and write projects for the Globe. I guess my first question to you guys, I know you're also working on the front lines doing clinical work during the pandemic, and we're seeing all these surveys of Canadians having self-reporting much higher rates of anxiety and depression. I wondered if you could speak a bit to what you're seeing on that front line. What's been surprising to you about the issues that people have brought forward? Even who's doing well? What has been kind of the protective factors for those people? Maybe some patients who kind of stand out in your mind. Whoever wants to go first. How about Patrick? Do you want to?
Well, I think that one of the things that we've all seen, and certainly I've seen in my clinical practice, is the risk of increased alcohol use in particular, and recreational drug use. And when this working group talked about mental health, we included addictions and mental health. And that's been a big challenge for a lot of people. People are isolated, people are lonely, and they may turn to alcohol. And it's very difficult for them to see that there's the consequences of that, because they may not be immediate consequences, although sleep disruption is, and then family disruption is sometimes a problem. And so those have come out. I guess the other area is that some people have benefited from it. Some people have organized their lives. I'm thinking of one family where they, in the face of a relationship breakdown, they the two members of the family moved together to supply the support for children involved in it, and they've done a wonderful job of creating a bubble that is meeting everybody's needs, and doing a wonderful job in that respect. So I think that there are good news stories, but in general, people who have mental health problems, I think, have suffered more than the average because of their mental health problems and the difficulty they have in getting care and moving forward with their own agenda.
I would maybe also draw on my experience. I'm the Chief Medical Officer of the Canada Suicide Prevention Service. And I think one of the things that surprised me, I mean, we know from a national survey, there have been a few. CAMH has done one, the CMHA has done another one, Canadian Mental Health Association. There are quite high rates of distress among the general population. Like about a quarter of people surveyed have significant depressive symptoms, anxiety symptoms, loneliness, and a lot of the anxiety symptoms do relate to worry about things related to the pandemic. So finances are a concern, worry about loved ones are a concern, and that those rates are increased if you work within or in relation to healthcare. So the degree of distress is, I found surprising in a way, just how prevalent it was. And also when we look at calls to the distress center, they're up 200% over last year at the same time. So I think it's a marker of the fact that people are struggling. But we also know some of the things that will work. So much like Pat was saying, there are lots of things that work, strategies that work for people. And connectedness, I think, is one. So the ways that the creative ways that people have found to be connected to each other, and then what we can all do as health providers to ensure that people can stay connected. That has really resonated for me.
Yeah, I would echo all of that. And I guess from my perspective, I'd add that, again, the pandemic sort of opens up those places where the most vulnerable are, and shows it to us very, very clearly. So, many of our mothers and young children, I mentioned, who are in, sort of difficult situations when it comes to domestic violence, our most vulnerable community members who are, addicted to substances or living on the street. When those types of services close, that need doesn't go away. In fact, in many ways, it sort of amplifies. So as those services began to resume, then you began to see again some alleviation of some of those acute difficulties that happened in the initial first wave. But the other area I see, in my clinical work where people are really having a difficult time is in families supporting children with developmental disabilities or autism. We've set up systems of services that require very specific diagnosis in order to access. So even as those other services come back online, now that there's a 8-month backlog in our ability to see people, for that type of thorough assessment in some cases, or, a few month delay in our ability to be face-to-face in a room to do a proper, autism assessment, for example, those wait lists grow, and the ability to access those services starts to, be very, very difficult. So I think that, those among us who are the most vulnerable seem to suffer disproportionately when it comes to the pandemic, and in particular because of the way we've set up systems and services around ourselves.
I know just interviewing people for stories over the last year, and even thinking for myself when we've written in the past about the epidemic of loneliness, I think it's really come home. The pandemic has really brought home the effect of loneliness. And, Chris, you mentioned parents with kids with developmental disorders or mental health disorders. The families will talk to me about just the loneliness they feel and the struggle, even while they're waiting for services and even getting services. And I wonder if we've kind of learned that, Allison, you talked about compassionate care. If we've learned that we need something, it can't just be about, you get your appointment, you get in line, you get your treatment. Like, people need support, kind of, if you're living alone, if you're, you just feel that sense of loneliness, that you need support in a different way. Do you think we've had our minds open to that? What can we do about that going ahead?
Well, much of that can't be done by the health system. And we shouldn't be thinking that all solutions are in healthcare. Some of the solutions are in better housing. If you have the opposite of loneliness, if you have 10, 15 people in a house that was really designed for 4 or 5, then you have serious problems. So I think that we have to look at each healthcare worker has to be compassionate and understanding and so on. But it's not, the issue of loneliness is not one that will be solved by the health system. And we have to think much, much broader than that.
Yeah, the idea of kind of a public health approach and a preventative approach to mental health and wellness comes to mind. And I don't think it's an area we really have invested in. I'm thinking of the UK with their loneliness strategy. So no one is saying that loneliness is a disease or a mental health disorder, but they are saying this is something that impacts all of us and has to do with social cohesion and with having flourishing communities. And how can we think from a more broad public health lens? I think that is an area that could be invested in.
Well, yeah, and I think part of it is in remembering lessons that we knew before in our, the mental health system as it sort of exists now is not very old. So we certainly did something before this. And we have to kind of think a little bit about what that was. I know in, many of our remote communities in the north here in Ontario, March coincided with different times when people would be on the land anyway. So what they did was they went out on the land. So now you're out doing your traditional cultural activities, hunting. Goose season was on, and you are able to physically distance yourself from other people when you're in the middle of nowhere. You're able to be in a bubble when you're in a hunting group with your family. There is adequate ventilation there, as well, plenty of clean water. So I think that in many ways, families and communities have been grappling with the isolation, with the loneliness question for thousands of years, and some of it is that embedded knowledge that we already hold within our cultures that we have to find ways of accessing now when we really need it.
Well, I know, one of the things you raised, Chris, was just how we can't just solve mental health with the system, as Patrick points out. We also have to look at all the areas around a person's life, like homelessness, unemployment, which all feed into that loneliness. I mean, we have huge jurisdictional issues in Canada around doing that. Do you know of any, are there some groups that are doing it well? Do you see some programs out there that we could look at scaling up? Do you have some positive examples of where they're kind of dealing with the whole person holistically?
Yeah, you know, there are examples that I'm aware of. Of course, this isn't an advertisement for work that I'm involved in, but I'm most familiar with work that I am involved in, of course. And, you know, there are, you know, youth mentorship type programs and approaches that are more holistic in orientation that we run out of our organization. There's homeless outreach and wraparound services that I've been collaborating with colleagues at CAMH on for a number of years, and others. And then there are the frameworks that have been developed policy-wise nationally when it comes to on-reserve addiction and substance use and solvent abuse treatment. You know, like the Honoring Our Strengths framework, or the First Nation Mental Wellness Continuum framework. And those frameworks are things that I talk about with non-Indigenous people as well, because I think at the center of them, even though the lessons are very, very embedded within, you know, cultural knowledge, they also make sense to everybody. So for example, you know, people need a purpose in their life. So each day you need to wake up and have something to do, and that people need some hopefulness around, you know, what the world holds for them and holds for their families. People need belonging. So that is within, you know, members of a family, members of a community more broadly. And people need meaning. It has to be for something, something outside of yourself, some larger reason. And, you know, those traditional teachings are fairly consistent with teachings from, you know, philosophers 2,000, 4,000 years ago in other parts of the world. So it's, you know, I think that what we've settled upon in many ways is what people need. And we have to find ways of bringing those lessons back into our homes as best we can, particularly when, you know, when we're limited in terms of how much interaction with others we can, you know, have. So, you know, one concrete example is from a purpose perspective, right? So if I think about being on the land, what does the land provide me? Well, it realigns my circadian rhythm to a 24-hour clock. There's no Netflix to binge when you're out in a tent, right? So how do I have to set up my house in such a way that I'm not staying up too late, or, you know, getting that, you know, reminder notice from Netflix that I'm now on my 4th episode in a row or whatever. Also, there are tasks that I need to do when I'm out on the land. Otherwise, they don't get done. So that's your structure. And that's really, you know, the active ingredient of most depression and anxiety treatment is the behavioral activation structure piece. And that's already embedded. You know, it's very physically active being out rather than in your house. So you've got to find that piece as well. And then what you're eating when you're out there is not, you know, food that comes in packages. It's very, very lean, very, very healthy food that doesn't inflame and doesn't cause further health issues. So, you know, if you can take those lessons best you can and bring them into where you are, wherever that is you find yourself, then perhaps that presents one underlying kind of orienting framework that we can use to kind of help build that foundation for wellness.
I wonder, Chris, that really reminds me, there's a study by Publié talking about what are the 4 evidence-based aspects of mental health strategies that work during the pandemic. And you just hit on all 4 of them. One is a sense of care or self-care. And as you say, which goes back to the Stoics and, you know, many Indigenous communities. The other is a sense of control, like being able to control the things that you can, such as, you know, having a schedule, etc. The other one is coherence or a sense of meaning. And the last is connectedness. And so all of those, like social connectedness, so coherence around the purpose. So you can hear that commonality. And I wonder if one of the kind of silver linings of this pandemic will be that we stop thinking about healthcare as just pills and, you know, interventions, and start remembering that biopsychosocial spiritual model of understanding somebody, and beyond the individual to the family and the community, because all are very necessary for wellness.
When you speak about thinking differently about the healthcare system, and all three of you have raised this idea of equity and equal access, but also if we think about the way we fund the healthcare, mental health care, it's very different than physical health. We would never tolerate, as a society, cancer patients waiting over a year for treatment or not having access to the best evidence-based care. We wouldn't send heart patients home from the hospital with no follow-up the way we do people who come in who are hospitalized or show up at emergency after a suicide attempt. Do you think the pandemic has helped us see that inequity and establish that importance in a different way? I mean, it's baffling to me that we still kind of accept one level of care for mental health that at a level that we would never be okay with for physical health. Can you guys want to speak a bit to that? Patrick?
Yeah, I think we see it, and people have always seen it. Whether we do anything about it is a different question. My belief is very strongly that we don't do it with mental health because we blame the people with mental health disorders, mental health problems for their disease. And we consider these people as less human, less, well, you know, I wouldn't do that. That's not my family. They're over there. And even in families, people who have mental health problems are shunned. And the people who are it's difficult because we don't have outstanding curative treatments for mental health problems. So that speaks to the need for a lot more research to figure out this treatments that may actually be curative. But I think we see it, but I don't think unless we all resolve, and there is, of course, beginning to move in that direction, not necessarily because of the pandemic, but I think we begin to see that that mental health is important. The public health publicity campaigns, for instance, in Bell Let's Talk, have brought a lot of people into the idea that we all have mental health issues in our families and in our friends, and we better, if we're going to have a better society, we've got to take care of that. The other thing is that there are some things like housing and guaranteed income that are marvelous mental health treatments, but we don't think of them that way, but they have a huge influence on mental health. So I think that we have to push for those types of things, and perhaps the pandemic has made it more visible, but because of the costs and because of the preoccupation with other issues, that it may be that we are not going to do anything about it, but I think we have to do it, not just see it.
I see one of our participants is asking some questions about how youth are doing, what you're seeing among your younger patients, some of the issues in the community, how we could better support young people who, as we know, are often resistant to getting care, don't show up for appointments, have to wait a long time to get treatment. What do you think the pandemic has highlighted for young people in Canada, especially? Chris, you want to start?
Sure. Yeah, no, it's a great question from Bonnie. So thank you for that. One of the things that our organization, did quickly once we sort of reestablished, what we were able to do under the health regulations was a lot more kind of yard visits and stuff at people's houses. So, it was, you can still, foster those relationships in a way that allows the relationship to develop outside the context of technology. Some young people find online, to be a little bit difficult. A number of my clients actually preferred it. They actually find it, a little more accessible. Young people are way more comfortable with technology than those of us who are a little older than young. And I'll leave that there. But so again, I think one of the challenges in mental health systems is we always sort of try to develop a one size kind of, for everybody sort of thing. And what we would probably benefit from is a bit of flexibility in terms of how we orient our services, such that, some people prefer something one way, some people prefer something another way, and some people prefer a blend of those two ways. So really, again, meeting client needs in a more flexible way is probably a useful approach there. But as well, engaging families, right? So if young people are having difficulty accessing service, coming to therapy, et cetera, really a lot of the support can be to family members as well, who are helping to support that young person in their life. And similarly to the last kind of point, it's like the more educated we are as citizens around best practice approaches to mental health and evidence-based treatments, the less likely you're going to go see a counselor who's going to administer a treatment that may not have any evidence for its effectiveness. So we don't tolerate that in other places of healthcare, but if you went to see a counselor of some kind and said, does the treatment you do work? And the counselor said, well, no, we've known since the 60s that it doesn't, but I just like doing it because that's how I was trained. You'd walk out of there. Like if that was any other place in the health system, you'd be like, well, that doesn't sound like that's right for me. And I think that the more we can, educate people around, what ought you expect when you go into a mental health treatment in terms of an evidence base for something like depression or anxiety, then families are empowered with the kinds of information they need to best support their young people as well.
I think too, we have to think of things like school and how they're set up, and are they the best way that the school is set up in this situation for our youth. The quadmester system here, where people have in high school they have two different courses, and that's all they take. Is that really working well for them? The lack of oftentimes the lack of opportunities to do physical exercise and for the young kids to get out and run, do things differently. Some schools make sure that happens. Other schools are not making sure that happens. So I think we have to look at all of the systems and try and figure out, are we meeting the needs of our children and youth?
I wanted to move a little bit to, what we've seen in terms of changes in the mental, how clinicians, the system, so to speak, has kind of stepped up during COVID. And I know, Allison, this is your key area, but the big transformation is, of course, virtual care, which you were advocating for long before the pandemic, and clinicians were slow to adopt it, even though a lot of patients reported were happy with it. The evidence came back that it was effective. What do you think was the resistance to that? And now that they're forced into it, people are doing it. What are you hearing back from clinicians about how it's working? Has their mind been changed, I guess, about it?
Yeah, it's a good question. And much like Chris, I'm drawing on the work we've done because it's what I'm most familiar with. But there's a fair bit of research out there. About a year before the pandemic, our group did a study looking at the use of virtual care, and less than 1% of people in Ontario were getting virtual care for their mental health needs. And we kind of had this hypothesis that the people offering virtual care would be younger. Not to be ageist about it, but we just thought, fresher out of school, more comfortable with technology. We found the exact opposite. We found that, in fact, it's people who had been in practice for a long time that were offering more virtual care. So I think there is something about we also know from research that people who are trained to use virtual care during their health professions training are much more likely to offer it. So I think there's been this real lag. It's funny that we even talk about virtual care as if it's an innovation. It's been around for decades and decades and used in other fields. So there's a lag in how we train people, how people think about receiving healthcare, that I think the pandemic will change a lot. It's going to take down a lot of those barriers, because if anyone was reluctant or had inertia to try it, now they've had to try it. And so I think that we're over that hump. But, you know, to go back to, I think it was Bonnie who put in the chat, students say people don't even look at each other, others' eyes online. So even though young people are much more comfortable with technology, I think we have to do a lot more to figure out what works for people using technology. Get young people in there to tell us, you know, how we should be offering healthcare. Look at, you know, how we facilitate these things. How we facilitate groups is a big, so group interventions. Pat, I think you do a fair bit of groups. But how do we do that, like, online? We need to figure that out so that warmth and connection is not lost. I think I was all over the place in my answer there, but lots of potential basically in virtual care, but it's by no means a done deal.
Well, you raised something in one of the papers that you wrote about if you've never met someone and then you start in virtual care, and just the challenge of that, which I think is interesting because I have teenage boys, and the people they're interacting with online are their friends who they also see in person. They're not talking to strangers that they've never met before. So that is, you know, do you see that as one of the challenge with youth? Even though they're very tech savvy, they're still maintaining it within, you know, for the most part within their social circle. And so then to talk to a strange adult virtually is off-putting. And maybe also for adults, do you find like that will the new system still need an in-person meeting and then go to virtual care? Can you start with virtual care and never meet in person? What are the challenges there?
Well, a program that I'm associated with is Strongest Families, and we started about 8 or 9, 10 years ago now. And we do everything virtually. We never see our clients. And we also have them seen, the therapists are paraprofessionals. And we get outstanding outcomes from that because we measure outcomes all the time. And we get really, really strong therapeutic alliance. In fact, 10 years ago, Dr. Patricia Potty, who's now the CEO of the organization, did her PhD on that and looked at the therapeutic alliance in virtual care. And that's only with the telephone, not with any sort of Zoom. And we've now, this year, I think we're going to be seeing 9,000 families across Canada with never seeing them face to face. And the outcomes are very good, and the people feel really connected. In fact, in some ways, especially without the visual component on the telephone, there may be some advantages, because then the person who is depressed and isn't dressed at their appointment time at 10 a.m., nobody has to know that. They won't see the kitchen that is a mess behind them, or they won't see the fact that they're obese. They can be whoever they want to be online, and all you hear is their voice. So I think that we can't say that virtual care is for everyone all the time, but we have to throw away some of our preconceptions that indeed you need to have this or you need to have that. Let's go back and find out what you do need and what the evidence is. And I think that we'll find out that virtual care is accessible, and it's, you know, in a lot of ways. When I was in Nova Scotia, I was arguing that we could have our visits, cut them in half. Now, of course, they've cut them to 10% of 90% of virtual care. But the thing is that we have to understand that for a lot of families, the face-to-face is a tax on them. They have to pay for transportation. They have to take time off work. With somebody a little bit older, you may have their son or daughter may have to drive them. And, you know, it wasn't unusual for people to drive for 4 or 5 hours to come and see somebody for, if it was a mental health thing, for an hour, but if it was a surgical visit for 10 minutes. And we have to reconceptualize that and throw away all our preconceptions and say, let's see how we can create a system that meets the needs of the clients or the patients rather than what we feel comfortable with. So the involvement of people with the lived experience is so critically important.
Chris, I wanted to ask you, because I think an obvious equity question comes up. If we're going to start going to more virtual care and we're going to make that a central point of our healthcare system, then we need people to be able to access that care with computers and with Wi-Fi. And we know that the most underserved areas for mental health are remote parts of Canada that probably don't have great internet. I mean, how do we need to invest in that infrastructure before we start saying this is how we're going to deliver care? What kind of issues are you seeing in your community?
Yeah, it's a great question. The investments are, some of them are on the way, right? There's been some infrastructure investments in Northwestern Ontario with respect to improving internet infrastructure for sure. So I think it has to be done simultaneously. It'd be better. I mean, the best time to plant a tree is 10 years ago, so that would have been the best time to have good internet. But we're not there, so the second best time is right now. And if we can kind of get that equitable access across Northwestern Ontario, for example, that could improve outcomes for a lot of people. But it's not just available Wi-Fi. It's like, can someone afford a smart device? And our platforms that we're using, they're always the latest and greatest. But if you're on an iPhone 6, maybe, I don't know, does the latest Zoom update speak with that older device, right? These are real practical, pragmatic questions as well. A lot of families that I work with, they don't have cellular contracts. They buy minutes because they can't afford to be on contract, or maybe they don't have the credit to be able to enter into that type of contract. So, there are a lot of systemic issues that need to be dealt with from a larger equity perspective as well. There have been conversations and calls to since we've gone virtual and we've been forced to go virtual so rapidly, that internet ought to be deemed an essential service, something that you can't deny somebody. If a child has to take school online, well, if you need to be able to afford a few $100s a year to buy that service, well, that's a bit of a barrier for many families, and I say that as an understatement. So certainly, when it comes to the virtual care conversation, big infrastructure investments need to be made in less fortunate or less serviced areas, but also in communities where access to those types of devices and services may be limited as well.
Sometimes I wonder, I mean, we're talking a lot about access to care, like improving access, but I wonder, how do we, in our desire to just expand access, how do we maintain the quality of the care that we're providing? Are those two issues sometimes in conflict with each other? Allison, would you like to take that question for starters?
Sure. I mean, I think one easy way around that, Pat already spoke about the importance of measuring outcomes. I think we have to go to recipients of care and their caregivers and ask them what they think about the quality of care that they're receiving, and look at that across different areas or different domains. So, does the care feel safe to them? And actually, in response to what Chris was just talking about, I was thinking about the important concept that we now think about in healthcare of cultural safety. Does the care feel safe? Does it feel like it accords with people's values and principles and priorities? And I think about some of the other stuff you spoke about, Chris, about land-based wellness and healing. Well, if we move to virtual, how does that get taken into consideration? And for other communities as well, if I'm seeing somebody in Sudbury who is concerned with mining, do I know about that, connecting with them from Toronto? It's not to say not to do virtual care, but to be aware of not to lose the importance of context and specificity and people's lived experience. And I think another way, so measuring and also involving people from different communities in developing services and making them meaningful are two important ways.
You know, I've written about measurement-based care, and I remember afterwards getting many emails from clinicians who felt it would erode the therapeutic alliance, that it wasn't how they'd been trained, that there was kind of a resistance to that. And I mean, it kind of reminded me of the resistance to virtual care as well. How do you see that when we talk about it? It's kind of like a jargony term. But how do you see that actually working in practice? Does that mean that clinicians do surveys and then they're tracked somehow? Like what do we mean when we say measurement-based care?
So for example, in my clinic, I have if I have a client with anxiety and depression, I have them fill out anxiety and depression measures every 2 weeks. So when I see that they're not getting better, but we're still very friendly on, and everything seems to be wonderful in session, I have a warning sign. It's not a you can't say that a measurement of depression, a PHQ-9, for example, is the be all and end all. But then that's an opportunity to talk to people about that. It's it seems on your scale, things aren't working. Do you have any idea why? I mean, we wouldn't. Can you imagine somebody in cancer not measuring outcomes? It's unheard of. And anybody who is afraid of measuring outcomes, they need to step back and say, well, who are they in the business for? Are they in the business for themselves, make them feel good and have a good income? Or are they in the business to help their clients get better? And if the measurements that we have now aren't the right ones, let's get better ones.
Yeah, and I think I would add, I think sometimes there's a perception by clinicians that the measurements are going to be a way of policing their work or something. And I don't think that's the intent. I think if we can train clinicians to be in the business of measurement as part of their own practice, then, you're kind of just overseeing yourself and helping to improve, your own individual level outcomes. I don't think it's about, necessarily about conversations over, professional autonomy and things like that. I mean, the evidence is very robust. There's a good evidence base, for example, in psychopharmacological approaches to mental health care. If you track it, people respond better to the medication. So it's very, very useful, right? And it's another way of improving outcomes incrementally. And that's what we're talking about, is finding as many incremental ways to improve outcomes, because change is incremental, and the more increments there are, the more change there is.
So true. It's and even the research that shows like how bad we are at changing strides or changing our strategy. We will tell both patients and clinicians, we'll just let something go on and on and on without changing strategy. So I think measurement helps have that dialogue, as Patrick was saying, and also helps you change strategies when something's not working.
I guess one of the things during the pandemic is we've certainly been doing a lot of measuring of how Canadians are feeling. I don't think I've received as many surveys on a weekly, monthly basis. So we're going to end up having this huge pile of research around how people respond to a pandemic, which will hopefully guide, going ahead. You guys have raised some excellent points: measurement-based care, the expansion of virtual care, making sure that we don't do a top-down approach, but are culturally sensitive and specific to communities. We only have a few minutes left. This is a question I always ask, and sometimes people don't like it, but eventually we'll be through this, hopefully by next fall. What do you think? What would be the low-hanging fruit, the change that you'd want to see you make sure that we've the lesson we've learned from the pandemic that we would, use going forward, even when we're kind of on the other side of this very difficult time? Patrick, do you want to?
Sure. I think that there's several of them, but one of them that I would like to emphasize is that whenever there is a crisis, whenever there is any problem like COVID, the effects of that are not uniform. The effects of that hit the people that are in the worst position to begin with. So they affect the poor, they affect the people with developmental disabilities. They affect the people who have pre-existing mental health or addictions problems. And we have to be aware of that and preventing that, because our systems don't deal very well with those people. We don't get into their space and help them as much. There are exceptions, and wonderful exceptions, but in general, we don't do that. And that's what the lesson I would think we should learn.
Chris, do you have some final thoughts?
Oh, sure. I didn't know, Allison, did you want to say anything about that? Okay. Yeah, I guess the question I've been asking myself a lot is, if it's good during a pandemic, then how come not other times? So, if being able to follow your patients virtually during a pandemic works well, then why not when there's no pandemic? Or if housing people who are homeless during a pandemic is good, then why not when it's, when the pandemic's over? And I think there's a lot of those questions that are going to, that we're going to have to talk about in a serious way. And I think one important thing is, what are we going to remember from this? And come the next time we're tasked with evolving social policies or talking about taxation reform or all these other types of issues that affect everybody, what lessons are we going to remember from COVID in terms of what do we need to, what do we need to do in order to, ensure that people have as robust a system of care around them as possible. I think that's one thing I'm left thinking about quite a lot.
Absolutely agree with both of those. Couldn't really say it better. I just think invest in mental health and be a bit more creative thinking about public mental health, public approaches to prevention and wellness and community connectedness. That's my takeaway.
Well, just as a final question, I know I'm not sure who we have following, if they're clinicians or individuals, people with lived experience, but we're about to, we're just starting a difficult winter, snowed for the first time in Ottawa. We're gonna, people are kind of unsure how well it's gonna go. Maybe we're not gonna see families for Christmas. As clinicians, I'd be interested in hearing, just even on an individual level, on a family level, what's your piece of advice, the thing that we should remember, when we're in the middle of all this come like January, that might help us, give us some resilience, protect us a little bit from what we're about to face. Allison, you're nodding. Do you have a thought?
Okay. Well, I know that what we're trying to do in our house, I have a 10 and 11-year-old. We're trying to find new ways of, having traditions. How can we translate those things? How can we continue to get outside? And how can we stay socially connected?
And I think the other thing that fits in very well with that is how can we be kind to those in our environment? How can we be supportive of them? How can we throw away some of the disagreements that really weren't that important and start over again? And also, how can we be kind to ourselves? How can we be a little bit less hostile and critical, as so many people with mental health problems are, and move forward? So kindness sounds corny, but it's important.
Yeah, and I think about on both, I think that for many at the initial onset back in March, there was this sense that people were just trying to get through it. You're just going to wait it out. And I don't know that just waiting it out is sort of the most effective or adaptive strategy. I think that, now that we're in it, we've learned a lot through the first wave, and now we have to think about a little more purposefully, what are we going to do over the next period of time? So, for example, during the holidays, and then the other piece I would say is that, the ability to tolerate distress is an individual difference variable, right? So some people are better at tolerating distress than other people are, but what we know is that, if we can do the things that we need to do to regulate our emotions, so to keep ourselves as sort of level and in balance as we can. So it's not our emotions making decisions for us, but rather it's a balance of our emotions that are informed by our thinking, or that inform our thinking. that will be best placed to tolerate that distress when it comes, because life is unpredictable, and just kind of out, I think is one strategy, but the other strategy is to try to find ways to navigate it in a way that that we know builds wellness.
Okay. Sorry about that. Just making a few notes. I mean, that's excellent thoughts for us to end our session with. Some self-compassion, as Allison talked about, kindness, maybe binging Netflix less and getting outside more, that Chris mentioned. Really important lessons. And I guess we can hope that we take those with us going forward when the pandemic is over into our mental health care system as well, and just remember those principles that make people feel better. Yes, I see your note. Netflix is also okay, Allison. We all need Netflix once in a while. Thank you so much, the three of you. I really enjoyed this conversation. You gave me a lot to think about for future stories, and I hope the people listening, everyone take care, and I guess stay safe.
Thank you.
Thanks, everyone.